department in Yenepoya Medical College. He is not only a good clinician but also an excellent academician, and he is also very approachable. I would like to call upon Dr. Sidney D'Souza, Professor in Anatomy Department of Yenepoya. I would like to call upon Dr. Ibrahim Masoodi, Consultant Gastroenterologist, Yenepoya Medical College, and Dr. Padma Shetty, Director of Laboratory, Shema, to chair the session, please.
It's my pleasure to introduce Dr. Rajesh Krishna, who has completed his MBBS from Government Medical College, Calicut, followed by MD in General Medicine at Madras Medical College, and then went to UK in 2004. Dr. Krishna completed his MRCP and joined for 5 years higher training in hematology in London, including Hammersmith Hospital and University College London, during which he attained his fellowship in Royal College of Pathology and CCT Hematology, with dual training in bioclinical and laboratory hematology, apart from bone marrow transplantation. Dr. Krishna worked as consultant in UK for 6 years. His special interests are dysproteinemias, such as myeloma and WM. I'm sorry to say, it's Waldenström's microglobulinemia?
Yes, correct.
Okay. He performed over 100 myeloma-related stem cell transplants and presented over 30 abstracts in conferences. Please give him a big applause. I see him as a very good clinician and a very approachable person who always helps us at times of clinical crisis. Please, Dr. Krishna, start the topic.
Thank you, Sidney sir, for organizing this Haemocon. The topic that I've been given is hematological emergencies, and this is a very broad topic, and the question is where to start and where to end. So I've decided to keep it at quite a basic level to give screenshots of emergencies for the purpose of postgraduates, so that you have some carry-home messages. So let's start with this 53-year-old lady who has been fit and well previously and who has presented to, let's say, medicine OP with fatigue, extensive bruising, and fever. So what I think would be done is a standard complete blood count, and because of the bruising, I think we would end up doing a clotting as well. And you can see that there is profound pancytopenia, and there is deranged clotting, normal renal function. What would you think of? What would you ask for the next, what would be your logical next investigation? As a hematologist, our favorite investigation is the peripheral smear. So what we would ask is for a peripheral smear, and this is the peripheral smear of this patient. Let me pause for a moment. Any takers? Yeah, excellent. So what you're seeing is, what you're seeing is these large cells with prominent granules and or rods. You can see that quite clearly there. So obviously, hematology is like the marriage of medicine and pathology, and it's important that a hematologist, runs to the lab and looks at the peripheral smear. So I saw this, or rods, and obviously the first thing that comes to my mind looking at this hypergranular variant of acute promyelocytic leukemia. So that's the first thing I would think of, and that is a very important hematological emergency. The reason for that being a hematological emergency is these patients are very coagulopathic. So they may bleed, they may have a thrombus, and I've seen a patient who's had both infarct and bleed in the brain. So the first 1 or 2 weeks of after diagnosis for these patients, they remain in a critical phase. So what do? So you start, you have to do a diagnosis. So get the bone marrow done and send a sample for, fish for PML RARA. So that's absolutely important because you need a diagnosis as soon as possible. And you start them on an all-trans retinoic acid. I'll come a bit later to say how it works. Ensure that the platelets are kept around 50, and also correct the clotting, fluid and electrolyte management. If they got an infection, manage that. So this patient, the next day, the patient develops a fever. So what are you thinking in terms of any takers from the postgraduates? So obviously this patient is neutropenic. So this has to be managed like neutropenic sepsis. So that's the second hematological emergency I would like to stress. So any patient who is neutropenic and develops a fever, you have to act very quickly. So it's a medical emergency. The ideal needle to patient time should be less than 30 minutes. So there are times when you are prescribed antibiotics and then you go to the OP or somewhere, come back in a couple of hours and find that it's not been given. So it's important to tell the nurse the importance of giving the antibiotic as soon as possible and ensure that it is done. This is to prevent mortality. And ensure that the patients are hydrated. Blood cultures are sent before the antibiotics. We should have sufficient broad spectrum antibiotics. Again, if you ask what antibiotic, it should be based on the hospital's microbiological profile. So I think that's something which the medicine, hematology, and the microbiology department should discuss to see what are the common organisms encountered in that hospital. I mean, after joining here, I've had the chance to discuss with our infection control team, and sort of we thought meropenem would be an ideal antibiotic as a first line for neutropenic sepsis patients. Also ensure that you send urine cultures. If you got crackles in the chest, get a chest x-ray done, because you got to find out the source of the infection and manage it appropriately. So remember, this is an absolute killer, and if you've got neutropenic patients, leukemic patients, ensure that you handle them properly. So what's written in the red is a absolute take-home message. The next thing is, we've got a hematologist working in this hospital, so we are managing more and more cancer patients. So obviously, a lot of them will have central lines. So the problem with the lines is, a lot of staff are not trained to handle the lines properly. So it's important that they are taught that. And if a patient has a fever, make sure that the cultures are sent from the line as well. And if somebody having a central line is severely septic, profoundly hypotensive, think about whether it's a line-related sepsis. And to save a life, you may have to pull out line, send the tip culture. It is possible that you may see multi-drug resistant organisms there. So going back to promyelocytic leukemia, which by itself is a hematological emergency. Now, this is actually a good risk acute myeloid leukemia. So generally, with acute myeloid leukemia, you divide them into good, intermediate, and bad risk depending on the cytogenetics. And of course, there are some molecular markers available at the moment. So here you have a translocation between chromosome 15 and 17, which is basically promyelocytic leukemia area of the chromosome 15 to retinoic acid receptor alpha region of chromosome 17. So it's a good risk disease. So the emergency is only in the first 2 or 3 weeks when they are coagulopathic. But once you control this and you start treating the patient, you expect them to do well. You expect these patients to recover. So that is another message. See, these patients will do well if you care for them, if you look after them well. So now, what does this all-trans retinoic acid receptor region do? So this is a region that promotes maturation of promyelocytes. So that is why you have the arrest at the face of promyelocytes, and you do a peripheral smear, bone marrow, you see full of promyelocytes. So the treatment is of course all trans-retinoic acid to bypass that block, and also the other treatment is arsenic trioxide. Now that combination is given, what's called the arsenic trioxide ATRA combination, and China and India have been the centers, particularly Vellore have written seminal papers on arsenic trioxide, and this is one area where India has led the West in development. Now, if the counts are high, one would categorize these patients into high-risk leukemia. And for high-risk leukemia, we would add chemotherapy as well. So it's important, out of the AML, you just subcategorize them further. So you treat them, you start giving them ATRA, you control the clotting, you control coagulopathy, everything goes well, you manage the sepsis. But then after 6 days later, the patient is quite tachypnic, has got a cough, and then you get this sort of a chest X-ray. So the question is, what do you think about? So again, generally you would think in terms of infection in neutropenic patients, but in APML patients, you have another complication which is called the ATRA Differentiation syndrome. So it was previously called the retinoic acid differentiation syndrome. So this is because when you're giving these the bypassing agents, that's ATRA, these promyelocytes suddenly start maturing into mature cells, and then you have a lot of these cells released into the bloodstream, into the lungs, into the vasculature. So that's why you get, it does not happen in all patients, but it can happen in a small subset. So it's important to recognize what happens, and generally we would treat them with steroids, and if you manage properly, again, you can control that. So to summarize, APML is an emergency, good risk disease, so manage the coagulopathy and start early treatment on suspicion. And I think it's important that whenever you suspect a leukemia, make sure that the peripheral smear gets looked at as soon as possible, rather than wait for a day or two before you get the results. So it's important to chase that, and ideally, a hematologist should go to the lab and have a look. I think the pathology department would see me going there every day, to look at the films. So this patient subsequently did well, and has been in good remission. So let's move on. So the next case I would like to briefly talk about is an 18-year-old girl, who is currently admitted in our hospital. So she presented with a fainting episode, a lot of bruising. Again, you can see anemia. Look at the white cell count. It's like, it's a whoppingly high 320, and again, low platelets. I think this would be like you would straight away think of a leukemia looking at that, and obviously ask for a peripheral smear straight away. And this is what the peripheral smear shows. So it's you can see sheets of these uniform looking cells with open chromatin, and obviously this is a acute lymphoblastic leukemia patient. And obviously, we would do the bone marrow, and we would also look at the cytogenetics, try to classify the patient based on the risk, so that we can decide how we treat this patient. But I think the focus of this talk is on emergencies, and so what's happened is, we made a diagnosis of precursor B lymphoblastic leukemia, and obviously the treatment always for ALL includes a steroid pre-phase which has to be given. So this patient, it's important to start the treatment early because of that high white cell count. And the next day, I noticed that the potassium has crept up. Look at the creatinine, that's gone up. So, what is the complication, or what emergency are we thinking now? So obviously, Tumourlysis syndrome is something we need to think of. Whenever a patient has got, a high white cell count or if there is a very high bulky lymphoma, huge lymph nodes, if they got raised LDH. So it's important that we keep this in mind and we plan adequately to prevent Tumourlysis. So I think everybody is aware of the signs of Tumourlysis: hyperuricemia, hyperphosphatemia, hypocalcemia, and of course raised creatinine and hyperkalemia. So the treatment is essentially, aggressive hydration. So this girl basically, I kept her at 125 mils of fluid per hour continuously on a 24-hour basis. I mean, obviously, if it's an elderly person, you would be more careful. You want to get an echo quickly to see what's a heart like before you give too much fluids. But for a young person, you can hydrate quite aggressively. And, allopurinol is a preventative drug. There again, inhibits xanthine oxidase, so thereby reducing the, uric acid released into the system. If you got a profound good-going Tumourlysis, I would think of rasburicase. It's a urate oxidase, thereby metabolizing the excess, uric acid levels. But again, this is quite expensive, and that was one of the reasons why I hydrated this patient quite aggressively rather than giving, lots of rasburicase. But it's always important to remember this complication. This patient, is still, the Tumourlysis has settled down very well, and I think we will start the next week's treatment. Next week, basically, the patient got admitted only last week. But, it's important to remember this complication. So let's move on to another case. So this is a 59-year-old man coming with shortness of breath, fatigue, headache, occasional visual blurring, and back pain. So obviously you got some red flags there, headache, visual blurring, and things like that. So you're thinking, what's happening there? Is it some sort of a neurological issue? But anyway, we ended up doing basic blood counts and basic tests first. Patient is anemic. Look at there's an abnormal renal function, but the liver function showed raised globulins. So that immediately, you ask, okay, raised globulins, that means excessive proteins. Is it myeloma? Is it Waldenstrom macroglobulinemia? What is it? So that should be in your thought process. So let me just quickly talk about what is serum protein electrophoresis. In this patient, we asked for a serum protein electrophoresis. So basically, you're electrophoresing the serum proteins, and the protein that's most abundant in the body is the albumin produced by the liver. And then you got the gamma globulins there, and the gamma globulins are polyclonal because you have been exposed to so many infections and so many microbes. But in a patient, with a dysproteinemia, you would see a spike here, which is basically an M-band or a monoclonal spike. So what that means is it's produced by a single clone because it's one straight spike. So again, some people have asked me, what are free light chains then? So you got an intact immunoglobulin, which have got heavy and light chains. Sometimes some of the clones, rather than producing the intact immunoglobulin, they may produce just the light chains. So it can be either kappa or lambda. So that's why often a myeloma screen has got both serum protein electrophoresis as well as serum free light chain assay. So this is the results of the electrophoresis of this patient. You can see that the IgG is quite significantly raised, and there is immunoparesis. That means there's a suppression of IgA and M bands. The paraprotein is elevated. Ideally, you should not have a paraprotein, and this patient has got a paraprotein of 62. Then there's a serum free light chain, lambda is elevated, and look at the ratio that's suppressed. So, I mean, this would meet the criteria for myeloma, but let's talk a bit more about that. We did an X-ray skeletal survey of this patient, and you can see lytic lesion, the classic pepper pot skull, and also if you look at the femur, you can see this large lytic lesion. So that's the importance of taking a full skeletal survey, because if you haven't picked this up, the patient is likely to fracture. So it's important that you detect that early and you manage, referring to your orthopedician, get a rod done. While the treatment of myeloma goes on, the treatment of the complication should go on simultaneously. So this is how a bone marrow looks like. Plenty of plasma cells. They are one of the beautiful cells to look at, despite the the nasty disease they cause. And the criteria is plasma cells should be more than 10% in the bone marrow. Cause nephropathy, which can cause a renal failure. So quickly run through the, because a lot of people get confused between myeloma, MGUS, asymptomatic myeloma. So for the purpose of PGs, I'm just going to quickly run through that. So for diagnosis of myeloma, you need three things. You need an abnormal protein, you need plasma cells more than 10%, and you need an end organ criteria, which is hypercalcemia, renal impairment, anemia, or bony lesions. If you have only an abnormal protein with no excess plasma cells and negative for the CRAB criteria, you would call it MGUS. And MGUS is pretty common. Nearly 3% of the people above the age of 60 would have MGUS, so it's pretty common. So presence of a small paraprotein does not mean it's myeloma. Now asymptomatic myeloma means you got the first two criteria but not the end organ damage. Conventionally, we have been watching and waiting, though there have been some trials regarding early treatment. So now I mentioned about a paraprotein of 62 grams. So this patient has come with headache, blurring of vision. So what's a complication there? So we got another hematological emergency. It is hyperviscosity, and it's important that we manage that straight away. The common causes include dysproteinemias, mainly Waldenstrom macroglobulinemia and multiple myeloma. So in Waldenstrom macroglobulinemia, the paraprotein is IgM. So that's a bigger molecule, and hence the chance of hyperviscosity is more. Or any leukemia with very high cell counts, again you are at a risk of hyperviscosity. Sickle cell anemia, sometimes if there's a massive crisis, you can get this. So the management, you hydrate the patient. If the symptoms are quite severe, if it looks like if it's a life-threatening, if they got severe hypoxia, they're going to ITU, or if they got severe neurological symptoms, then it's important that you consider a plasma exchange to remove the excess paraprotein. They're at a risk of thrombosis. Consider a DVT prophylaxis provided the platelet counts are reasonable, and obviously start managing the cause. And fluid and electrolyte balance is quite important in this set of patients. So again, this is not exactly this patient's problem, but I thought it would be good to keep this MRI film here. So often you have patients coming with weakness of the legs. You got to think of cord compression, which is another hematological emergency. Can happen in diseases like myeloma, where you have either like a myelomatous growth or an unstable fragment there causing the cord compression. It can happen in some lymphomas as well. So it's important if somebody comes with sudden weakness of the legs, you think of cord compression, particularly so if they have had, if they are known to have hematological disorders. So cord compression, weakness of legs, bladder, bowel dysfunction, it's important they be managed as an emergency. Get an MRI spine done as soon as possible. We start them on high-dose steroids. You need a neurosurgery opinion there, because if it's an unstable fragment, then you need the neurosurgeons to stabilize the spine. Often we find that it's more because of myeloma-related soft tissue growth or something like that. And often they respond well to steroids and radiotherapy. So it's important that you do an MRI scan and discuss as soon as possible with your other multidisciplinary colleagues. And of course, definitive management comes later. So this is again another take-home message about getting an MR done, starting steroids, and discussing with other experts. So quickly about natural history of myeloma. So it's not a curable malignancy, incurable disease, but often these days we got plenty of medicines. So the patients live for many years rather than months. So good treatment is important. So there's a smoldering myeloma, MGUS stage, active myeloma. You treat, they go into remission or plateau, relapse, and then eventually after 3 or 4 lines of treatment, they may go into refractory disease. These days we got like 5, 6 different lines of treatment. I think the limiting factor is only the money, because in our Ayushman scheme we have only 2 lines of treatment approved, and for a patient who can afford, then probably we got more medicines. So essentially the treatment depends on whether they are fit for a stem cell transplant or not. If they're fit, then you give induction treatment followed by a stem cell transplant. If they're not fit, then you give less intense therapies. This is just to mention about agents which we use. Usually 3 drug or 4 drug combinations are used. So quick mention about another complication that can happen in a transplant patient. So now we find that in many more centers, we have started doing stem cell transplants. So this was something which I put in to alert our postgraduates, because we do have some patients on and off in our transplant bed. So it's important that we recognize that these patients are quite immunosuppressed, and because of the T cell immunosuppression, if we give them transfusion, these transfused T lymphocytes can engraft and can attack the patient's body. So they may have skin rash, liver dysfunction, diarrhea, and this is invariably a fatal complication. And to prevent it, we use irradiated blood products. So it's important that you get a call from the ward, and in the middle of the night you decide not to rush and give blood transfusion. Important to discuss with the hematologist or oncologist who is managing the patient. This is my last case. Let's talk about some non-malignant case. So this is a young lady who's got a lot of bruising, like any hematology patients, anemic, low platelets, and headache. As a good hematologist, we look at the peripheral smear. I think Govind had touched on this earlier. So I think any takers, what is this spotter? Yeah. So you see these fragments or schistocytes. You see polychromasia. So here, what should run through your head is, can it be a TTP, which is another hematological emergency? And essentially, you got the pentad, which I think every postgraduate knows by heart. We were talking about quiz yesterday, and I was talking about TTP, and I was told, oh, everybody knows the pentad. Let's not put this in the quiz, because everybody will tell the answer. so it's thrombocytopenia, microangiopathic hemolytic anemia, fever, renal failure, and neurology. So it's important to, this is just to sort of drum it down as a take-home point. So again, the problem here is, there's an enzyme deficiency of ADAMTS13, which is a von Willebrand's cleaving protein, as I think Govind discussed this a bit more. So basically what it causes is, it does not cleave the von Willebrand's factor, and you got these large aggregates, large multimers, and they would lead to cause platelet aggregates in the multivasculature. So that's what causes the chaos and thrombocytopenia and the other issues with the TTP. So what you do is, once you've made a diagnosis, you go for a plasma exchange. Again, as I have not sent a sample yet from India, but I think Hiramat lab in Bangalore does ADAM TS13. It's an expensive test, but it can be done. We have had recently a diagnosis of TTP associated with pancreatitis, and again, that was a first association that I've seen. So I went back and looked at the guidelines, and that's a clear entity. TTP associated with pancreatitis is a clear entity. So the treatment is basically you do plasma exchange, 1 to 3 volumes for the first 3 days, give steroids, and of course folic acid, because there's a hemolysis going on. After 3 days, you reassess. You may still have to continue plasma exchange, but monitor the blood counts, monitor the renal function, and also the blood films on a daily basis. And when the patient improves, you have to add aspirin and heparin, because it becomes a prothrombotic condition. I remember in UK, one of the patients we had went home and didn't take aspirin, and then he presented with a myocardial infarction. So you have to remember to prescribe the patient aspirin. So a quick word about differentials. Hemolytic uremic syndrome is quite closely related condition. One of the things to distinguish it is there is an oliguric or anuric renal failure. So the renal failure is generally more profound in HUS, and of course there's a history of diarrhea. Then other question we ask is, can it be DIC? So that was one of the things I asked when I was called to see that patient with pancreatitis. Why can't it be a DIC related to pancreatitis? And then we looked at the clotting, and in DIC, clotting is abnormal usually, and the DIC score also needs abnormal clotting for a diagnosis. So I've not gone into the details, basically because it's a last lecture, and basically I just wanted to reiterate the take-home points with regard to these emergencies, to recognize them. I would be happy if we as postgraduates can pick up some of these emergencies and manage them more aggressively and quite early. Especially, I think neutropenic sepsis is something you will encounter on a regular basis. So at least let's manage these things more, better. Thank you.
Thank you, sir, for the wonderful talk. I think it was very useful both for physicians as well as pathology people. Any questions?
Modify your treatments depending on the level of the.
So what I do is, if the patient is neutropenic and has a fever, then I think we need to start the antibiotics as soon as possible. So what I do is, I do clinical examination and to see whether we got a clear focus of infection. So first send blood culture, start a broad spectrum antibiotic. Here in this hospital I decided that myeloma probably is more suitable, and if the patient was more hypertensive, I would add amikacin along with that. And then, of course, chest X-ray, urine cultures, and see whether try to see whether we can get into the focus. Now, if we don't have a focus, then I would just carry on with these antibiotics and monitor the patient. So generally, the best dictum is you don't change the antibiotics for at least 48 hours unless you get a culture positivity. And then the standard is after 48 hours, you may change to another broad spectrum antibiotic. If it is like, their tazocin or piptaz was the first line antibiotic, and after 48 hours, we would think of meropenem. If they had a line related sepsis, then we would think of a gram-positive cover with vancomycin or teicoplanin. Again, if any chest X-ray had some, any features in the lung, we would consider HRCT. After 72 hours or 3 days, if there is ongoing fever, then I think we would think in terms of fungal infection and add antifungal agents. And again, an HRCT would be helpful there. But I think in the Indian setup, I think you got to remember that we have multi-drug resistant organisms. So I think a close monitor of the patients is important, because last month we had a death with Acinetobacter baumannii, which was resistant to all organisms. So I think it's important to think of what could be the organism. So if the patient is rapidly deteriorating in spite of your antibiotics, I think the way that we would do in the West, where we would just sit and monitor the patients, would not hold true. I think you will have to think in terms of, okay, these organisms have been in the hospital before, so should we start tigecycline or something like that? I think that is something that we have to decide early on in an Indian setting. Other thing is that history of tuberculosis is important. If people have had previous tuberculosis, then I would think in terms of INH prophylaxis before starting any chemotherapy. So again, that's again something. Then of course, Prashant has told me anecdote of people in hematology wards developing malaria in Mangalore. So it's important that you do the baseline test, check for malaria, dengue, you got mosquitoes here. But I've seen one patient, long years back. I worked as assistant to one of the eminent physicians then called Amarnath Hegde. We were referred a patient in Tejaswini Hospital, soon after it started, and I was his assistant physician. There was a patient with cellulitis, and the patient had fever, and the normal antibiotics were not working. And then after a day or something like that, then we tested for malaria, and that was positive. So it's important you think of the other things also, rather than just think it's neutropenic sepsis. Then one other thing is, I mentioned about the line, whether you need to take off the line. Again, I wouldn't, if I was a postgraduate, I would discuss with that the primary physician of the patient before taking the line out, because it's not easy to put in a line again. So, that's how I would think of. So it's a bit more complex than a one-liner, I would agree with you.
One thing not related to febrile neutropenia, but one of the emergencies sir has mentioned. In India, it's very common you find these relatives coming and asking you, no, for my father's, father requires a blood transfusion, doctor, you give only my blood. I don't want somebody, unknown person's blood to be given to me, to my father. This is very common, extremely common. By chance, if you agree for that and you do that, what you will have is TAGVHD, transfusion associated graft versus host disease. Because generally when you transfuse, what happens is that our body's immune system recognizes those T cells and destroys. Whatever donor T cells are there, that will be destroyed. But by chance you give a blood relative's blood to that patient, then what happens? They share the HLA antigens. So there will be a partial recognition of these T lymphocytes by the immune system of the recipient, thinking that it's my own cell. But the same T cell may not be so kind enough to the recipient, rather it will proliferate and it can kill the patient. This has happened in front of my eyes. I have the first-hand experience, that's why I'm telling you. In Narayana, when we were training, one patient came for dengue, and he was given 4 units of platelet transfusion. That's all was given. 2 days later, full rashes, complete desquamation, 5-grade fever, hypercytokainemia. We didn't know what was happening. My boss told, go and check what was the blood products that were given, from where they came. He just told me that. Went and checked. That time there was a scarcity of platelets, so they were asking everybody who are coming, you please donate, donate, donate. Unfortunately, this patient received his own son's platelet. There was some screening failure there, so they issued the patient's son's platelet to this patient. Patient died. We couldn't save. Because once TAGVHD comes, forget it, it is 100% fatal. Nobody can save the patient. So this is something I should tell every PG, don't entertain relative transfusions. Okay?
Thank you very much. Before, I would like to just share one hematological malignancy who presented to us as a general gastroenterologist. I came across a girl, 16-year-old girl who presented with severe hematemesis, hypotension, shock. So all of us were scared what all is going on. After initial resuscitation, we found that her hemoglobin was 2 grams. And she had pancytopenia. On further evaluation, she proved to have B12 deficiency. So B12 deficiency should be thought as one of the causes presenting as an aplastic crisis-like illness. So the hematemesis probably was one of the reasons that she had hemorrhagic manifestations of B12 deficiency. So B12 deficiency, apart from this, can be a presentation as pancytopenia.
And that's also a cause for unconjugated hyperbilirubinemia,
Exactly.
isn't it?
Thank you very much for this excellent talk.
Thank
you. Yes, there is one question.
Sir, DVT in a patient with thrombocytopenia, how to go about it? It's a very difficult decision for a clinician because the patient who is having hematological malignancy has a thrombocytopenia, now he develops a DVT in front of us.
As soon as Bala got up, I knew there was going to be a bounce. So I mean, yeah. I think this is a good question because you see, we have leukemia patients who have got a central line because you need to give chemotherapy and you put them on central line, and often there is a line related thrombus, and you find that the patient's platelet count are 20, 10, what do you do? So, the general dictum in the West was that we were giving platelets to raise the platelet count above 50 and then giving full anticoagulation. But then, sometimes this is like counterintuitive as well. And, how I would go about that is if the platelet counts are really low, around 10 to 20 or something like that, and again depends on how extensive the thrombus is. If it is just in the, the brachial vein or cephalic vein, I would, I would just, observe them, and if when the platelet count goes above 50, then I would start anticoagulation. But if you got extensive thrombus in many of the the subclavian vein or internal jugular vein, then you are asking for trouble. So you will have to give platelets and you will have to anticoagulate initially. Of course, if it's a lower limb DVT and you are not able to anticoagulate, you can think in terms of a filter. But always when you put in a filter, you have to remove the filter. So this is tricky. And in ALL also, when we give asparaginase, sometimes you can get thrombus. So, it's sort of at the discretion of the physician. You think of, a level of platelet, usually 30, 40. We end up sometimes anticoagulating, adjusting the doses and things like that. It's not easy. It's very difficult.